Good morning, everybody. Thank you, Meenakshi, for having me in your course. So we've already listened to two secondary glaucomas, and now I'll be moving on to the third topic, which is post-traumatic glaucoma. What is traumatic glaucoma? Traumatic glaucoma refers to cases in which a direct injury to the eye has led to the development of glaucoma, either acute or chronic. It's therefore a secondary glaucoma. To begin with, there may be only just a rise in intraocular pressure with or without a glaucomatous optic neuropathy. If untreated, it can eventually result in the typical glaucomatous optic neuropathy. Ocular trauma can either be blunt or penetrating. Blunt trauma is normally caused with simple objects like toys or household appliances, and penetrating injuries with sharp objects like bow and arrow, firecracker-related injuries, airbag-related motor vehicle accidents, etc. And proper treatment of the injury can help preserve sight to a large extent. What do we actually need to know? We need to know anatomical considerations of a closed globe injury. So we need to know what happens to the cornea, to the anterior chamber and the angle, the iris and the ciliary body, the lens, the vitreous, and the posterior pole. So you have to do a detailed examination, and you can see various anatomical structures that can be actually affected due to a blunt or a closed trauma. On clinical examination, you got to do the slit lamp and the fundus examination. You might have to sometimes resort to an ocular ultrasound, a gonioscopy, or an imaging of the globe, the orbit, and the adnexal structures. You have to look at treatment considerations, both initial and subsequent, because there may be a worsening of the condition, there could be development of complications, there could be an improvement of the condition, or there could be contraindications and side effects of the medication that you have to look at. You have to look at the visual prognosis as well, because visual prognosis can be affected with complications, with other associated injuries, many risk factors come into play, and with both medical and surgical intervention. Let's look at this case. Here was an 18-year-old male patient who presents with an injury with a ball. When he comes to you, he just comes with a history of pain, redness, and reduced vision. On examination, his best corrected visual acuity was 618 in the affected eye and 66 in the other eye. The orbit is swollen, the palpebral fissure is also narrowed. The cornea shows some stromal haze. This is what the patient actually looks like. The anterior chamber shows a hyphaema with some cells. The pupil is mid-dilated and reacts sluggishly to light. The lens is clear. The fundus shows some macular edema. The intraocular pressure is 26 millimeters of mercury. What do? You start wondering, what all do I treat? Because the hyphaema is not so much, you can still wait and watch. You can see that the pressure is high, so you probably want to work on the pressure. Patient has got pain, so you want to treat his pain. And generally, you just monitor this patient basically. The patient comes back after 2 days with a further loss in vision and an increase in hyphaema. The fundal glow can now only be seen from the upper margin of the pupil, and the intraocular pressure has now gone up to 34 millimeters of mercury. And why do you think this must have happened? It's because of the very common phenomenon of a rebleed in an hyphaema. So the high intraocular pressure in the acute phase post-blunt trauma can be because of many reasons. It can be due to the hyphaema itself. It can be due to traumatic iridocyclitis. It can be due to a lens which can be dislocated, subluxated, or ruptured. There could be a shallowing of the anterior chamber due to uveal effusion. There could be peripheral anterior synechiae, epithelial and fibrous growth, vitreous disruption and presence in the deep anterior chamber, tears of the non-pigmented epithelium of the ciliary body along with retinal detachment causing an IOP fluctuation, which is the Schwartz-Matsuo syndrome. You got to also know the grading of the hyphaema. So depending upon the amount of blood, you can have a microhyphaema, a grade 1 hyphaema where you have less than 1/3 of the AC filled with blood. You can have a grade 2 where you can have 1/3 to 1/2 of the AC. Grade 3 where it is 1/2 to less than total volume of the AC. Grade 4 where you have blood filling the entire volume of the AC, or you could have an 8-ball hyphaema, which is a total hyphaema of the purplish black color. Now these are all the various grades of hyphaema that you can actually see. Hyphaema, will ultimately lead to a rise in intraocular pressure acutely. It is raised due to the occlusion of the trabecular meshwork by the clot itself, the inflammatory cells, or the red blood cells. Pupillary block can happen secondary to a clot involving both the anterior and the posterior chamber, that is the 8-ball hyphaema. Usually, the larger the hyphaema, the greater is the chance of the rise in IOP. In patients with sickle cell disease, a high IOP can be seen even with a very small hyphaema. And the visual prognosis and complications are worse in the presence of a total hyphaema as opposed to the subtotal hyphaema. Eyes with total hyphaemas are more likely to require surgery than eyes with partial hyphaemas. Complications due to hyphaema can be directly attributed to the retention of blood in the anterior chamber, and 4 most significant complications are posterior synechiae formation, peripheral anterior synechiae formation, corneal blood staining, and ultimately a glaucomatous optic atrophy. Rebleed in hyphaema is a very common phenomenon. It's due to clot lysis or retraction. It can cause a substantial increase in the hyphaema size. It may be associated with complications like a rise in the intraocular pressure, could give rise to corneal blood staining, optic atrophy, peripheral anterior synechiae, and the incidence of surgical intervention is definitely very, very high. The risk of rebleed, however, is not related to the size of the hyphaema. So you could have a very small hyphaema like the case that I showed you, which can also give rise to a rebleed. Corneal blood staining occurs when the hemoglobin and hemosiderine enter the corneal stroma, and blood staining is more common with larger hyphaemas, rebleeding, and prolonged clot duration with a sustained elevated intraocular pressure and corneal endothelial cell dysfunction. This is what a corneal blood staining looks like. So you see that on slit lamp, you see a straw yellow discoloration of the deep stroma, greater centrally than peripherally in the early stages, and corneal blood staining remains for years and does not respond to medical treatment. So you have to make sure that you don't allow corneal blood staining to happen. You have to look at the posterior segment, meaning you have to do a dilated fundus examination for complications secondary even to the initial trauma. Posterior segment injuries are significant predictors of poor visual outcome. Detection of these findings can be challenging either because of poor visualization, because there is either a hyphaema or a full chamber vitreous hemorrhage. And at such times, you might have to resort to doing an ultrasound to look at the integrity of the retina. So various stages of your vitreous hemorrhage can be imaged easily on a B scan. How long do you need to follow up a patient with a trauma? Once the acute phase is dealt with and the vision is restored and the IOP is back to normal, what next? Do you need to see this patient again? If yes, for how long and why? The answer obviously is that you have to look for predictors of post-traumatic glaucoma. So there could be a presence of increased angle pigmentation, there could be a hyphaema, there could be a lens displacement or an injury to the lens, there could be an angle recession which is more than 180 degrees, and you could see a wider angle on UBM, and if you see any of these, you can be sure that you're going to have not very good vision, or you're definitely going to land up with a glaucoma of a greater strength. Now, a late onset glaucoma, for days to years after the initial injury, you can actually see a late onset glaucoma because of angle recession, peripheral anterior synechiae, the ghost cell or the khaki cell glaucoma in cases where there has been a vitreous hemorrhage. In cases where there have been retained intraocular foreign bodies, there could be an ongoing inflammation with cyclitic membrane formation. There could be an ingrowing epithelium or, of course, not to forget, sympathetic ophthalmia. What happens in angle recession? The presence of an angle recession does not equate to glaucoma, but there is a tear in the ciliary body, and that is not the cause for the glaucoma. The trauma stimulates proliferative and degenerative changes with subsequent scarring of the trabecular meshwork, and hence there is an IOP elevation, which usually presents with 2 peaks of onset. The first peak is seen around 3 months post the injury, and the second may be seen as late as after 10 years after the injury. And hence it's very important to keep following up these patients for a long, long time. And what will you see on gonioscopy? You'll just see this big brown band of the ciliary band body, which is, of course, showing you a large angle recession, because the angle is really big. Recess of the angle can now be seen. A total of 5 to 20% of patients with traumatic angle recession will ultimately go on to develop glaucoma. The possibility of developing glaucoma in an eye with an angle recession appears to be related to the extent of the angle recession, and there is a much greater chance of developing glaucoma if the angle recession is more than 180 degrees. Gonioscopy therefore is a must, as it delineates angle recession from peripheral anterior synechiae or a downgrowth as the cause of glaucoma. A dilated exam also must be performed to rule out subtle evidence of zonular dialysis, and an indirect ophthalmoscopy with indentation needs to be done to rule out peripheral retinal dialysis or breaks. There is also some amount of genetic predisposition to the incidence of traumatic glaucoma, because in patients who've got angle recession, the intraocular pressure in the eye that has not got the injury also seems to have fluctuations to steroids, and they are steroid responders. So probably there is also some amount of genetic predisposition. Now, what is ghost cell or khaki cell glaucoma? Distorted non-pliable khaki-colored RBCs migrate from a resolving vitreous hemorrhage and block the trabecular meshwork. The RBCs are trapped in the vitreous and they transform as they age within 1 to 3 weeks from pliable biconvave cells to rigid spherical khaki cells due to partial loss of the hemoglobin, and residual intracellular hemoglobin denatures into Heinz bodies which characterize these cells. So if you can look at this, the picture down there shows you a lot of khaki cells in the anterior chamber, and up you can see the candy stripe sign, which is very, very typical of a khaki cell or a ghost cell glaucoma. The rigid khaki colored RBCs lower the outflow facility 3 times more than fresh red blood cells. Hence, the red blood cells lay down in the anterior chamber in tan colored stripes and can be confused with a hypopion. If there is a concomitant fresh blood, then the ghost cells occupy the tan stripe in the background of the fresh red blood cells, and hence you see this candy stripe appearance. If you have a total anterior dislocation of the lens, it can lead to angle closure and secondary glaucoma due to a pupillary block. Posterior dislocation is less likely to cause glaucoma, but if the vitreous prolapses, then there could be a pupillary block glaucoma which may ensue. If the dislocated lens becomes cataractous and the lens proteins leak, you could also have a phacolytic glaucoma. So you could have dislocated lenses in various stages, and it's not just the natural lens, but you could also have now a pseudophakic eye which has an IOL dislocation. Penetrating injuries, the initial and intraocular pressure is naturally going to be low because there is an open globe. After the wound closure, however, glaucoma may develop because of structural alterations and blockage of the trabecular meshwork by blood cells because of hyphaema, inflammatory debris, lens particles, or ghost cells can also be seen. Secondary responses such as inflammation may lead to synechial closure of the angle. An angle closure may occur due to iris bombay, synechial closure at the pupillary margin, or a lens swelling. There could also be a long-standing vitreous hemorrhage. And you can see various kinds of penetrating ocular injuries. What are the management principles? You need to take an orbital X-ray, do an ultrasound or other investigations. Surgical management of a penetrating injury is a must because you have to close down the initial injury. Prophylaxis of an intraocular infection. Follow-up includes examination for possible sympathetic ophthalmia affecting the fellow eye, which is seen very rarely, but you can't afford to forget that it can happen, and look for traumatic glaucoma. What do you do in normal traumatic glaucoma? The basic principle is that you just lower the intraocular pressure. Like always, using medications is the way. Other contributing factors have to be looked at, and at times, surgery might have to be resorted to. So what medications can you use? Normally, beta blockers, alpha agonists, and carbonic anhydrase inhibitors do the job very well. The drugs to be avoided, however, are pilocarpine and prostaglandin analogs. Sometimes systemic acetazolamide might have to be resorted to, and obviously, because there is inflammation, judicious use of steroids and mediatic cycloplegic combinations has to be thought of. For ghost cell glaucoma, medical treatment usually suffices as the condition is usually transient. Rarely, however, a vitrectomy with an anterior chamber washout is required to control recalcitrant glaucoma. An open-angle glaucoma post-trabecular meshwork scarring responds pretty well to medications. The surgical intervention is required in case of hyphaema, where you can do a paracentesis depending on the intraocular pressure and the optic nerve head status. In healthy eyes, if the IOP is greater than 50 millimeters of mercury for greater than 5 days, if the pressure is 35 millimeters of mercury for greater than 7 days, if the hyphaema is greater than half chamber or a total 8-ball hyphaema for greater than 7 days, if there is a corneal blood staining that you are even doubting about, and sometimes a lensectomy and a vitrectomy is solicited. In case of sickle cell disease, the use of systemic acetazolamide can cause a sickle crisis. So, its use in sickle cell trait is not contraindicated, but the child should be well hydrated. Intravenous mannitol needs hematological surveillance in the presence of sickle cell disease. Coexisting problems like cataract and amblyopia need to be treated simultaneously, and both eyes of a patient with unilateral angle recession needs a long-term follow-up for glaucoma. Thank you very much.